بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Now we will handle the last part of the topic concerning the imaging of diffuse lung disease using high resolution CT. And we have finished with the uh, two or three patterns. The first one is the reticular pattern, number two is the ground glass pattern, and number three is the alveolar pattern. Now we will deal with the nodular pattern. And the nodular pattern, by nodular pattern, we mean that there are too many very small nodules scattered throughout the lung. And concerning this pattern, we should be careful about the distribution of the nodules, and this will affect the way of differential diagnosis. And we have three patterns of distribution: the lymphatic distribution or perilymphatic distribution, which is arranged along the septae of the intralobe of the pulmonary lobules, as well as along the bronchovascular markings. And then the second pattern is known as the centrilobular pattern, where nodules are located inside the center or approximately at the center of the lobule. Then the random pattern, where the nodules are distributed haphazardly throughout the lung. Then this is the outline that we will follow in order to reach the differential diagnosis. And first, look at the interlobar fissure, and this will make you to identify at least the perilymphatic pattern. Whenever you see that the the fissure is thickened and you see nodular opacities along the fissure, then you know that you are dealing with the perilymphatic distribution. The most common and important topic in this issue is sarcoid. Then you have lymphangitis carcinomatosa and the pneumoconiosis. Okay. If the nodules are distributed in the center of the lobule, then you are dealing with one of three: hypersensitivity pneumonitis, we have dealt with before; bronchoalveolar carcinoma, we have also been dealt with before; and sometimes of some types of pulmonary infection. Then we came to the random distribution, and if the nodules are randomly distributed throughout the lung, look at the size of the nodules. If the size is 3 millimeter or less, then consider number one, biliary tuberculosis, the possibility of metastasis, and the possibility of fungal infection. But if the nodules are larger than 3 millimeter in size, consider only metastasis. Then this is a very good example of a perilymphatic distribution, where you can see, if you enlarge this image, and you see the fissure is thickened and you see nodules arranged along the fissure. And some of the nodules are arranged along the septal lines, and by this we mean that we are dealing with this distribution, which is known as perilymphatic distribution. On top of the differential diagnosis of perilymphatic distribution is sarcoid. And you remember lymphangitis carcinomatosa is diagnosed whenever you know that the patient had a primary malignancy and you see the perilymphatic distribution. Then what about sarcoid? By sarcoid, this is the granulomatous infection, or the granulomatous disease affects the lung and many other systems, and it is classified into stages. And there are two ways of staging this disease. The first way is to consider that the stage one is in the form of the presence of hilar or mediastinal lymph nodes only without any changes in the lung parenchyma. And stage 2 means that you have nodes or no nodes, but you have affection of the lung in the form of linear opacities, and this is stage 2A, perihilar opacities and nodules, and this is stage 2B, the combination of opacities and nodules, and this is stage 2C, then coarse parenchymal involvement is stage 2D. The final stage, or let us say end stage sarcoid, is irreversible pulmonary fibrosis, and I have mentioned this in the first part of this lecture. Then the second way is to consider a patient known to have sarcoidosis with no lung disease or no thoracic involvement, and this is stage 0, which is seen in about 10% of the cases. Stage 1 with hilar and mediastinal lymphadenopathy. Stage 2 with mediastinal lymph nodes and interstitial opacities. Stage 3 is the interstitial opacities together with very lymphatic nodular distribution, and the stage 4 is the end stage or irreversible damage of the lung. Then if you look here and you see that the hilum is enlarged on both sides, and you consider this either vascular uh, or nodal enlargement. Then you look to the lateral view. If you see an extra density superimposed on the hilum, and this is lymphadenopathy. But if you do not see any extra density superimposed on the hilum, and this is vascular. But you are sure that these are lymph nodes because you see also paratracheal lymphadenopathy and the lobulated outline of the affected nodes. And sarcoidosis is a multisystem granulomatous disease of unknown etiology. 90% of the patients with sarcoid have thoracic manifestations. You remember, 10% do not have thoracic changes. Stage 1 is in the form of enlargement of the hilar lymph nodes. The nodes are almost bilateral and symmetric. They are homogeneous density. They may contain calcium and they have a lobulated outline. Sometimes they are known as potato lymph nodes. Then stage 2, where you see lymphadenopathy and strandy opacities in the lung, and this is stage 2B, where you can see nodes and you see strands and you see very lymphatic miliary shadows or the nodules distributed in the very lymphatic distribution. And then if you look here, the stage 2 sarcoid, if you have hilar nodes with streaky opacities, and this is stage A, hilar nodes with streaky opacities and miliary shadows, and this is B, the combination between A and B is stage 2C. And here you see the classic appearance of sarcoid nodes, which are homogeneous, discrete, and may contain calcium. In the lung window, you can see the typical perilymphatic distribution, and you see the micronodules together with strandy opacities. And this is also a stage 2C sarcoid, where you can see enlargement of the hilar shadows due to lymphadenopathy, as well as perilymphatic distribution of the nodules together with interstitial opacities. And the long-standing disease will lead to pulmonary fibrosis, and you got the full-blown picture that has been previously mentioned in the form of traction bronchiectasis, honeycombing, interstitial opacities, and ground glass areas. Then we came to the pneumoconiosis, which means that there is inhalation of high concentration of dust, which will lead to multiple nodular shadows scattered throughout the lung. They usually spare the apex and the base, and they may contain calcium. The nodules are very dense compared to other miliary nodules. If you look here in this chest X-ray, you see miliary shadows together with interstitial opacities, and you can compare the density of the miliary shadows here with the density of miliary shadows in a patient with miliary tuberculosis. Then one of the complications of pneumoconiosis is the development of progressive massive fibrosis, which means that the nodules coalesce together to form big masses, classically in the upper part of the chest on either side of the mediastinum. And these masses usually contain calcium. And sometimes, if you look carefully through the lung field, two, you can see multiple small, dense nodules scattered in the remaining part of the lung. In this patient with increasing shortness of breath has a history of a metal exposure and he is non-smoker. And the chest X-ray shows the classic appearance of progressive massive fibrosis in the form of two big masses in the upper part of the lung, and these masses are associated with reticular densities together with miliary shadows affecting the rest of both lung fields. By CT scan, you can identify that the masses are solid, they contain calcium, and they have irregular outline as you can see. And also, if you look in the mediastinum, you may have slightly enlarged lymph nodes that may contain calcium as well. And this is the classic appearance of progressive massive fibrosis in the form of two big masses in the upper part of the chest. The masses contain calcium. They may show some internal air bronchogram. The remaining part of the lung shows many miliary shadows representing the pneumoconiosis nodules. Then, what do we mean by centrilobular nodules? We mean that the nodules are located within the central part of the lobule. And you remember that the respiratory lobule is hexagonal in shape and is located in the periphery of the lung, in the area within 3 centimeter of the lung periphery. Also, it is related to the interlobar fissure. If you can identify centrilobular nodules, then you may diagnose hypersensitivity pneumonitis. You remember, hypersensitivity pneumonitis is diagnosed by the presence of um, ground glass opacities and a positive history of exposure to allergens, and sometimes you can see these centrilobular nodules. In cases of bronchoalveolar carcinoma, centrilobular nodules may be seen together with patchy opacities containing air bronchogram representing the coalescence of these nodules into patches, and this may also indicate the presence of pulmonary infection. One of the appearances of the centrilobular nodules is what is known as trium pod appearance, which means that there is mucus or pus impaction in the respiratory bronchioles or in the centrilobular bronchioles. The impacted mucus or pus within the bronchiole will give the typical appearance of the tree on bud. And this means or almost always indicate that there is an endobronchial spread or transbronchial spread of infection, particularly TB, airway disease associated with infection like cystic fibrosis and bronchiectasis, airway disease associated with mucus retention like allergic bronchopulmonary aspergillosis and asthma. And this is the classic appearance of tree on bud opacities in the high resolution CT, and this is what do we mean by tree on bud. Then the tree on bud means that there is mucus, fluid, or pus infection within the terminal bronchioles. The opacities are related almost to infection, and one of the major causes of this Trion body is the tuberculosis, which in this stage will be an active form of TB. Then a typical mycobacterial infection or infection bronchiolitis and diffuse ban bronchiolitis may produce this appearance. The trion bud appearance has a very, very long list of differential diagnoses. And this is just a demonstration of a case of bronchiectatic changes, a cylindrical dilatation of the bronchi together with, you see, these two many trion bud appearances, which indicate transbronchial spread of the infection. And this is a case of infection bronchiolitis, where you can easily appreciate the classic appearance of trion bud opacities. Then we came to the random pulmonary nodules, and for these random nodules, the size is very important. If the size is less than 3 millimeter, then you consider tuberculosis, miliary TB, and also you may consider metastasis if you know that the patient had a primary malignancy, and sometimes you consider disseminated fungal infection like in immune compromised patients. But if the nodules are larger than 3 millimeter, consider only metastasis according to the literature. And miliary TB may be a primary infection and may be a post-primary infection and is usually associated with poor prognosis. It is the hematogenous dissemination of the disease and will result in extensive nodular opacities randomly distributed in the lung, and they are usually in the range of less than 3 millimeter in diameter. If you look to the chest X-ray, sometimes it's difficult to appreciate that this patient had miliary shadows. You may also feel that there are patchy opacities and miliary shadows together with strandy opacities. And if you remember, I have mentioned that if you are not able to identify the pattern of the disease from the chest X-ray, and this is frequently seen in the clinical practice, then you should go to the high resolution CT. At that time, you can see that there are miliary nodules randomly distributed throughout the lung in a patient with cough, low-grade fever, night sweats, weight loss, and pneumoctosis. Then this was a miliary tuberculosis. And this is one of the important statements in the literature that miliary TB is one of only a few causes of miliary opacities on the chest radiograph. And sometimes patients who are HIV positive may have miliary tuberculosis, and at that time you can see that the shadows are bigger than 3 millimeter, but you consider that the patient is immune compromised and the lesions may be a little bit larger. Then if you see random distribution and the nodules are less than 3 millimeter or more than 3 millimeter, consider the possibility of metastasis, particularly if you know that the patient had a primary malignancy. And it is well known that thyroid cancer is one of the most common causes of miliary deposits in the lung. Also, you consider pancreatic cancer, breast cancer, and melanoma. The differential diagnosis will be with sarcoid and miliary TB and silicosis. Of course, sarcoidosis has very lymphatic distribution, lymphadenopathy, and so. But miliary tuberculosis, the nodules are randomly distributed, but they are less than 3 millimeter in diameter. And in cases of silicosis, you may see that the nodules are very dense, and also you may see the complication of progressive massive fibrosis. This patient with papillary thyroid carcinoma showed multiple miliary shadows in both lung fields. The CT scan showed extensive pulmonary nodules of variable size distributed randomly through the lungs, diagnostic of metastatic deposits. Then we finally came to the cystic pattern, which is the last pattern of diffuse lung disease. And by cystic pattern, we mean that we have multiple thin-walled air-containing lesions, 1 centimeter or more. The differential diagnosis include Langerhans cell histiocytosis, emphysema, cystic bronchiectasis, tuberous sclerosis, lymphangioliomyomatosis, and lymphocytic interstitial pneumonia. First of all, you should know that the cystic pattern cannot be appreciated from the chest radiograph because you only see the wall of the cyst, and the wall of the cyst will appear like linear strands throughout the lung. Then you may feel that you are dealing with an interstitial lung disease of the reticular pattern. But if you have the CT scan, then you can see that the lung is involved by variable size cystic lesions containing air with distortion of the lung parenchymal architecture. Now, what is the Langerhans cell histiocytosis? This means that there is accumulation of histiocytes in the lung, and this disease is intimately related to smokers and is seen in the second to the fourth decades of life. Classically, the cysts are big, they have thick margin, and they are distributed through the upper and middle parts of the lung. They spare the lower areas as well as the anterior segment of the middle lobe and lingual. Then if you look here and you see a more or less classic appearance, multiple cystic lesions scattered throughout the lung field. The cysts are of relatively thick margin. They have irregular outline. They can spare parts of the lung parenchyma in between. The infiltration by histiocytes will form at first nodules, and the nodules will coalesce and cavitate, and resulting in cysts with thick margin. Then the margin will be thin. Then you got finally complete destruction of the lung and fibrosis at a stage that sometimes it's difficult to be differentiated from emphysema. Of course, any of the cystic lesions in the lung may rupture and result in spontaneous pneumothorax. The incidence here is about 15% of the cases. And this, I can say that this is a classic appearance of histiocytosis in the lung. If you look carefully, you see that the cysts are bizarre in shape, they are variable in size, they have thick margin, they can spare part of the lung in between. Some cases will show scattered pulmonary nodules. The cysts do not usually affect the lung basis, and the volume of the lung is preserved. Then in the chest X-ray, it is difficult to appreciate that this is a cystic disease. But in the CT scan, you can easily see that the cysts are scattered throughout the lung. They affect mainly the upper and the middle lung zone. They spare the basis of the lung, and sometimes the cyst may rupture, results in pneumothorax and surgical emphysema. This is the final stage of histiocytosis, where you got uh, destruction of the lung with too many variable size cysts with relatively thin wall, and this appearance is difficult to be differentiated from emphysema unless you have the background and the clinical data sufficient to diagnose histiocytosis. And pleural effusion and lymphadenopathy are not features of this disease. In order to manage histiocytosis, first of all, stop smoking. Then corticosteroids will help to cause disease remission. However, in about 10 to 20% of the patient, progressive destruction of the lung with spontaneous pneumothorax and progressive respiratory failure may occur. Then we came to the second one in this category. Well, first, the histiocytosis, then the lymphangiomyomatosis, which disease results in a proliferation of abnormal smooth muscles, which will obstruct the veins, the lymphatics, and the airways. This is a rare multi-system disease, affects many organs in the body, and sometimes it occurs in association with the tuberous sclerosis. The disease commonly affects young women of the childbearing age, and The patient may present by dyspnea, recurrent pneumothorax. These are the two common presentations. In the plain X-ray, it is difficult to appreciate that this is a cystic disease. Only you see multiple widespread reticular opacities throughout the lung fields, which may represent the walls of the cysts. But whenever you have the high resolution CT, then you can see that this is extensive, numerable, almost of similar size and relatively thin wall compared to those of histiocytosis. And very importantly, these lesions affect the lung basis, the whole lung, and they reach even the costophrenic angles. And this is important. And if you consider the sex of the patient, the age of the patient, the distribution of the cysts, and the size as well as the thin wall, you may be easily reach the diagnosis. This is the female patient, 38 years old, and the chest high resolution CT showed extensive widespread cystic lesions of thin wall scattered throughout the lung fields. Of course, similar to histiocytosis, one of the cysts may rupture, resulting in a pneumothorax, as you can see in this case. Lymphangiomyomatosis may be associated with abdominal findings like renal angiomyolipoma, which is the most common and is usually bilateral, masses containing fat affecting the kidneys. Sometimes you got splenic cysts, sometimes you got chylous ascites or lymphangiomyomas in the abdomen, uterine fibroids, and abdominal lymphadenopathy. The differential diagnosis will include the Langerhans cell histiocytosis as well as the lymphocytic interstitial pneumonia. Lymphocytic interstitial pneumonia is associated with autoimmune diseases, as I will mention. Langerhans cell histiocytosis, the cysts are, are bigger, they have a thick wall, they spare the lung basis, they, they affect younger patients in children and young adults with no sex predilection and intimate relation to cigarette smoking. And by emphysema, we mean that there is a pattern of air trap in the lung, and this has been previously described thoroughly in the literature considering the plain X-ray findings, which include hyperinflated lung, low flat diaphragm, ribbon-shaped heart, prominence of the central hilar vascular shadows, scanty peripheral vascularity, widening of the retroesternal space, and widening of the retrocardiac space. And sometimes in the plain film, you may be able to see emphysematous bully. And this is the way how can you measure the retroesternal space, which is the distance from the back of the sternum to the anterior border of the ascending aorta. And this distance should not be more than 2.5 centimeters. Also, this is a way to know if the diaphragm is flat or not. You identify the copula of the diaphragm and you draw a tangential line from the ends of the copula. Then you draw a perpendicular line from the highest point of the copula, and this line should be more than 1.5 centimeters. Of course, the hyperinflated chest do not require the previously mentioned measurements, but it's easily to appreciate that the retrosternal space is wide and the retrocardiac space is also wide and the diaphragm is flat. There are three types of emphysema: the centrilobular type, the paraseptal type, and the pan-acinar type, which is the mixture of both. This is the paraseptal emphysema, where you can see multiple emphysematous bulli containing air of thin wall arranged in the subpleural area and also along the fissure. The centrilobular type, we see the emphysematous bulli with the same criteria scattered within the central part of the lung. in the mixed type or the pan-assigner type, and you can see the paraseptal emphysematous bully, and you can also see emphysematous bully within the lung parenchyma. And this is the centrilobular type of emphysema. Also, you should know that emphysematous bully do not have a appreciable wall, which is completely different from the histiocytosis and the lymphangioliomyomatosis. If you look here, and you cannot appreciate that there is a wall. The wall is very, very thin, and there are remaining parts of the lung which is not yet affected. Emphysematous bulli are usually located in the subpleural area, considering the costal margin and the mediastinal margin. They are filled with air and they have a very thin margin. One of the possibilities in this domain is the tuberous sclerosis, which is an autosomal dominant disease, affects equally males and females, usually in the third and fourth decade. The disease affects the lung in a similar way to the previously mentioned lymphangioliomyomatosis. But here, the disease affects both males and females and is usually associated with angiomyolipoma of the kidney, either unilateral or more commonly bilateral masses containing fat involving the renal parenchyma. The lung changes are almost seen only in females. Tuberous sclerosis affects males and females. The lung affection is seen in females and is similar to lymphangioliomyomatosis. This patient presented by mental retardation and seizures. In the brain, you can see the classic appearance of tuberous sclerosis in the form of subependymal nodules and tubers that are calcified, and we see giant cell astrocytoma as well. In the chest, you see too many small cystic air-containing lesions, and in the abdomen, it is frequently to see the angiomyolipoma, either unilateral or bilateral. And this is a case of multiple cystic lesions in a patient with tuberous sclerosis. If you know the clinical data of the patient, it's easy to reach the diagnosis. But of course, if you do not know the clinical data, this may simulate pneumocystis pneumonia, for example, if this is an HIV positive patient. In the abdomen, you can see the fat-containing lesions in both kidneys representing angiomyolipomas. And this is the case of tuberous sclerosis with lung affection and bilateral renal angiomyolipomas. Finally, we came to the cystic bronchiectasis, and by cystic bronchiectasis we mean that there are cystic dilatation of the bronchi. Frequently, they show in the plain X-ray multiple air fluid levels due to the superimposed secondary infection. Sometimes it is difficult to identify tubular bronchiectasis in the chest X-ray, but cystic bronchiectasis are easily appreciated in the plain radiograph. Then the high resolution CT findings of bronchiectasis include too many of the signs, and you got the increased bronchoarterial ratio. You know that the ratio between the bronchus and the adjacent vessel, this is the bronchus and this is the adjacent vessel. The range may be in the form of 0.6 up to 1.5, and this is usually seen in the normal individuals. To remember that we used to diagnose bronchiectasis when the bronchus A caliber is larger than the adjacent artery. They they should be of equal size, but if the bronchus is large, we consider bronchiectasis. Then you may get mucus infection, like in cases of cystic fibrosis, for example. You may get areas of air trap and mosaic appearance. You may get transbronchial spread of infection and the tree and bud opacities, as I have mentioned. And these are the signs, which the tram track sign and the signet ring sign and the string of pearls sign. The string of pearls means that you got too many dilated bronchi arranged in a single line like this, and we call this the string of pearls. And this is the tram track appearance where you got thickening of the wall of the dilated bronchi, giving this sign. And this is the signet ring sign where you see the dilated bronchus and the adjacent artery. The dilated bronchus is the ring, and the adjacent artery is the stone. And here you can see the classic appearance of the signet ring appearance. The bronchus is considerably dilated compared to the adjacent artery. And here also, you can see the classic signet ring appearance. And the cystic bronchiectasis can be seen in patients with tracheobronchomegaly, can be seen in cystic fibrosis as well. And the diagnosis is easy whenever you see these lesions arranged along the distribution of the bronchi. The distribution of bronchiectasis depends on the underlying pathology. Upper lobe bronchiectatic changes are usually seen in cystic fibrosis and tuberculosis. Central bronchiectasis in the middle lung zone, like they are seen also in cystic fibrosis, and allergic bronchopulmonary aspergillosis and congenital tracheobronchomegaly. Lower lobe bronchiectasis are seen in a childhood infection, aspiration pneumonias, and immunodeficiency. And this patient with extensive cystic bronchiectatic changes showing most of the previously mentioned signs like the string of pearls, the track sign, and signet ring sign with multiple air fluid levels representing superadded infection. The coronal reformatted images are of valuable help in the diagnosis of cystic bronchiectasis to see the distribution along the bronchial tree. Then the last one in this category is lymphocytic interstitial pneumonia, which means benign proliferative disorder with lymphocyte infiltration of the lung. And classically, this disease is seen in adults in the age around 50 years. And if the disease is seen in the children, this is an indication that the child is HIV positive. But this disease is intimately related to autoimmune disease. The patient should have a known history of an autoimmune disease, especially this one, the Sjogren syndrome, so that it's easily to appreciate or to reach the diagnosis. This patient is middle-aged HIV positive man with long-standing asthma. The high-resolution CT shows many cystic changes in the lung, and the cysts are distributed haphazardly. The wall of the cyst is more or less thin. The cysts are variable in size, and the lung parenchyma in between is almost normal. And patients may complain of gradual onset of dyspnea and cough for about 6 months duration. Sometimes they complain of fever, night sweats, and arthralgia, and the disease may progress to respiratory failure. In about 20% of patients, you got affection of the salivary glands. Of course, Sjogren disease is a well-known disease that affects the salivary glands and lacrimal glands as well. And by high resolution CT, and you got ground glass opacities, and you got scattered the thin wall cysts deep in the lung parenchyma. The cysts may range from 1 to 3 centimeter in diameter. They may be associated with with mediastinal lymphadenopathy. I will repeat that you cannot appreciate that you are dealing with cystic pattern of diffuse lung disease from the plain X-ray of the chest. Only you feel that you are dealing with a reticular pattern, with you may feel also some cystic changes, but the high resolution CT is diagnostic in this particular domain. This patient with Sjogren disease, which is one of the diseases commonly associated with this type of pneumonia, which is known as lymphocytic interstitial pneumonia, and you see the cystic lesions in the lung. Similar to any cystic lesion in the lung, they may rupture and they produce pneumothorax. The differential diagnosis of lymphocytic interstitial pneumonia include number one, pneumocystis jirovecii, and it is difficult to differentiate lymphocytic interstitial pneumonia from pneumocystis carinii pneumonia because both are related to an autoimmune diseases and both can be seen in patients with HIV positive. Then, considering lymphangioliomyomatosis, the patients are younger females. The cysts are of uniform distribution and they affect the costophrenic angles. Histiocytosis, patients are a smoker. They are young, a child and young adult. The cysts are bizarre. They affect the upper and the middle lung zones and they spare the lung bases. To conclude, we have 5 patterns of diffuse lung disease. The first pattern is the reticular pattern, and by this pattern we mean that there are multiple interstitial reticular opacities scattered throughout the lung. If these opacities are associated with ground glass and bronchiectasis and honeycombing, then the diagnosis will be usual interstitial pneumonia. And if you cannot identify an underlying pathology, then the diagnosis will be idiopathic pulmonary fibrosis. And if you see these changes with no evident honeycombing or no honeycombing at all, then you are dealing with non-specific interstitial pneumonia. If the patient is known to have congestive heart failure, then you are dealing with interstitial pulmonary edema. If the patient is known to have collagen disease like rheumatoid, then this is rheumatoid lung, scleroderma, and this is scleroderma lung. If the patient is known to have drugs which produce interstitial opacities, then you are dealing with drug-induced interstitial lung disease. Then once more, if you see these changes, the diagnosis is usual interstitial pneumonia. If no underlying cause, it is known as idiopathic pulmonary fibrosis. And if you see these and you can, the patient is known to have primary malignancy, especially if the lesions are in the lymphatic distribution, then you know that you are dealing with lymphangitis carcinomatosa. If you know that this patient is a sarcoid patient and this is in the stage sarcoid, stage 4 sarcoid will result in interstitial opacities, ground glass lesions, bronchiectasis, and honeycomb. Then the ground glass pattern, we have described the acute form, which means the types of pneumonia, some types of pulmonary hemorrhage. And we also said some words about acute respiratory distress syndrome. And the ground glass pattern is chronic, and the patient is known to be exposed to allergens, then you are dealing with hypersensitivity pneumonitis. If you see the lesions with the reverse of halo sign or the atoll sign, then you are dealing with cryptogenic organizing pneumonia, and one of the issues that help in the diagnosis is the absence of response to antibiotics. Then if you can see the crazy behaving pattern and the patient is a smoker, then the diagnosis is alveolar proteinosis. Then you came to the alveolar pattern. If the patient had multiple patchy opacities and he has constitutional symptoms like fever, cough, and sputum, then the diagnosis will be the pneumonia. If the patient is known to have congestive heart failure, then the diagnosis will be alveolar edema. If the patient showed the crazy behaving and he is a smoker, then you diagnose alveolar proteinosis. If the patient had hemoptysis and is known to have one of the lesions that are associated with vasculitis, like systemic lupus or Wagner granulomatosis, the diagnosis will be pulmonary hemorrhage. In cases of bronchoalveolar carcinoma, it is usually difficult to reach the diagnosis from from the CT scan. But if you remember that I have mentioned that if there are nodules and patches, this is one of the helpful signs. If there is a mass with air bronchogram, and this is a helpful sign, but the CT angiogram sign is not helpful. Then what are the differential diagnosis of multiple patchy opacity stimulating pneumonia with no response to antibiotics? First, number one is the acute eosinophilic pneumonia. Acute eosinophilic pneumonia presents as patches in the lung which do not respond to antibiotics. How can you confirm the diagnosis? By CBC, you can see significant eosinophilia. By bronchial lavage, you can see significant eosinophilia and the dramatic response to steroids. Number two is the cryptogenic organizing pneumonia, which will result in patches do not respond to antibiotic. How can you confirm the diagnosis? By the reverse of halo sign or the atoll sign if present. Number three is the bronchoalveolar carcinoma. How can you confirm the diagnosis? By the presence of combination of nodules and patches, mass with air bronchogram, and then CT angiogram sign. In case patients with lymphoma may present by patches simulating pneumonia with failure to respond to antibiotics, then if the patient is known to have lymphoma, this will help. If the patient has mediastinal lymph nodes, this will help. Patients with atypical pneumonia, like pneumonia of the fungus etiology, TB etiology, or patients with alveolar sarcoid, which is a type give, resulting in patches in the lung, simulating pneumonias, not associated with lymphadenopathy and not associated with perilymphatic spread. Then, if you do not have conclusive clinical and laboratory findings and the imaging findings are not helpful, then the only way to reach the diagnosis in this category is the biopsy. Then we came to the nodular pattern, which means that there are many nodules scattered throughout the lung. We have three patterns of distribution. The random distribution consider the size of the nodule. If it is less than 3 millimeter, consider at first biliary TB metastasis, then and fungal infection. But if the nodules are randomly distributed and they are larger than 3 millimeter, consider metastasis. The centrilobular nodules consider the hypersensitivity pneumonitis, bronchoalveolar carcinoma, and pulmonary infection. Perilymphatic distribution consider first sarcoid, then pneumoconiosis, and the lymphangitis carcinomatosis. Finally, the cystic pattern. We have the Langerhans cell histiocytosis, and the patient is a smoker. The cysts are of thick wall, they spare the lung bases, and there are some nodules. The second one is lymphangiomyomatosis. The patient is a young female. The cysts are of thin wall. They affect the whole lung, especially the costophrenic angles. A patient with tuberous sclerosis, they have cysts similar to lymphangiomyomatosis, especially in female patients. They may have mental retardation and the skin tumors of tuberous sclerosis, and of course, angiomyolipomas in the kidneys and other parts in the abdomen. In cases of cystic bronchiectasis, and you can see the previously mentioned signs, including the tram track sign, the signet ring sign, and the string of Pearce sign. And lymphocytic interstitial pneumonia. Number one, patients with autoimmune disease. Number two, ground glass opacities, thin walled cysts, and mediastinal lymphadenopathy. Thank you very much. Alhamdulillah Rabbil Alameen. والصلاة والسلام على رسول الكريم.